Good morning again, everyone. I'm Dr. Karen Sketsina, and I'm going to be getting us started today. It's 11:02. I think we may still have some folks join this call. As people join in, feel free to introduce yourself via the chat. And I am director of the Child and Family Health Institute. I am not sitting out in the woods today. I'm actually in the hospital, so I'll probably be taking my mask on and off and possibly turning my camera on and off. But we do try to make our Zoom collaborative series as interactive as possible. So feel free to leave your camera on if you're able to throughout this session. I also invite you to put in questions or comments through the chat at any point during the session. And you can also use the Zoom feature to raise your hand or chime in at any point to ask questions or share comments. We should have some time at the end of the presentation for some discussion and networking. So we are thrilled to have Dr. Lindley Wolf here today as our presenter. She is going to be talking about management of acute hypertension during pregnancy, as well as how this relates to efforts to prevent maternal mortality. So she is an assistant professor at the University of Tennessee Medical Center. She is board certified in both obstetrics and gynecology and maternal fetal medicine. She's a graduate of ETSU. She then went on to complete medical school at St. George's University, residency training at the University of Tennessee, Chattanooga, and then fellowship training in maternal fetal medicine at the University of California, San Diego. We're very happy to have her today. Throughout her career, she's won multiple teaching awards. And I got connected to her through our respective work with the Tennessee Initiative for Perinatal Quality Care. So this is a statewide quality collaborative, and birth centers and professionals in our region and throughout the state work together through this collaborative called TIPQC to help to improve health and well-being and outcomes of babies and moms throughout our state. So one of the current areas of focus for TIPQC is preventing maternal mortality, and one of the specific projects aimed at accomplishing that is improving management of acute hypertension during pregnancy. So welcome, Dr. Wolf. We are excited to have you here today.
Great. Thank you, Dr. Sketsina. Okay, so hopefully I'm off mute and I will go ahead and share screen. Sound good?
You are off mute, and I did want to also remind everyone that we record these sessions and then post them on the Child and Family Health Institute website. So yeah, go ahead and share your screen, Dr. Wolf.
Oh, okay. Did it work? No.
I can see you. I can't see your screen yet.
Okay. Back into, I had this down a second ago.
Yes, we practiced this, but
this is why. Okay, wait. Zoom meeting. Oh, here it is. Okay. Got it. Okay.
Yeah, there we go.
Very good. Fantastic. All right, great. So I'm going to just start right out by asking a question. How many of you all have been involved with or taken care of or had somebody you know have preeclampsia or toxemia? Probably the majority of people. Well, in the state of Tennessee, between the years of 2017 and 2019, 10 women lost their lives to preeclampsia or hypertensive disorders. And the Maternal Mortality Review Board, the Tennessee State Review Board, decided that all 10 of those women lost their lives, that death was preventable. And so today we're going to talk about ways to recognize this disorder and intervene that and literally can change lives. So we'll start off with some facts. Preeclampsia complicates about 5 to 8% of all pregnancies. And if we include hypertensive disorders, we're going to increase that to over 10%. Baseline chronic hypertension, we'll increase that to over 10%. Worldwide, this results in 76,000 maternal deaths and over 500,000 infant deaths. So it's a pretty big deal. And that's why we're going to focus on the management of acute hypertension in pregnancy, as this is where some of that morbidity and mortality is coming into play. So here's my little picture. I am, as you all went through all my bio, a maternal fetal medicine specialist. I'm also a Buccaneer previous and a Kappa Delta from ETSU. But aside from my educational background, our bread and butter in maternal fetal medicine is hypertensive disorders. That's one of our main things. So it's something that I do day in and day out. In addition to that, I am a member of the Tennessee State Maternal Mortality Review Board, where we review all deaths in the state of Tennessee. And I'm going to throw in a couple of slides later on about how that works and what we do. But what also makes me somewhat of a preeclampsia expert is, as you can see my picture there, I had my first little boy at the age of 40. And first pregnancy, advanced maternal age, big risk factors for preeclampsia. And I actually did have mild preeclampsia without severe features these days when I delivered. So in addition to taking care of it, I myself had it as well. So we're going to focus on 3 key ideas. We're going to talk about the prevention of maternal mortality first, treatment and guidelines for acute severe hypertension, and then tie all this in with the impact of racial disparities. So a little bit of housekeeping first. If there is, I have no financial disclosures. If there's questions, I'm pulling up the chat box. I'm trying to balance it all, but certainly anyone just chime in at any time and say, hey, I have a question, unmute yourself, or if somebody raises his hand and anybody recognizes it, just interrupt me and we'll talk about it. As we mentioned, there's slides in here that are from the Speakers Bureau, and then I've mixed in some of our own so that we can hopefully have a discussion and talk about some relevant things. There's probably not a lot in this that's going to be like earth-shattering, new, or groundbreaking, but I'm hoping to bring out some best practices and points to remember, things that bring to light some of our disparities and situations that we can be aware of so that we can take home some things moving forward. Again, if you have questions, just ask about it. So let's get into first the prevention of maternal mortality. This has been a hot topic in the news in the last few years. NPR's done segments. There's been multiple, news interviews with big name anchors talking about this increase in maternal mortality. And a lot of the discussion is talking about reducing the rate of maternal mortality, and specifically in the US. And the reason is because the United States is the only developed nation with a rising MMR. So in 2015, if you look at the graph, there was about 26 deaths per 100,000 live births. And if you compare that to the other developed countries, you can see none of them were over 10 per 100,000. So there's big differences. So we got interested in, like, what can we do to talk about where can we intervene? Why are these deaths happening, and where can we intervene? And the National Vital Statistics System actually looked a little bit deeper and tried to, like, are we coding properly? What are we doing, and why is our number so high? So first, if we focus on the World Health Organization's definition for maternal death, it's a pregnant woman or within the 42 days after she delivers. That's how they define the maternal mortality rate. And when they looked a little deeper and got a little bit better with their coding, they actually found some people that weren't pregnant coded as pregnant. And they honed in a little bit, and we actually were able in 2018 to say that was actually 17.4 per 100,000 lives birth. But that's still so much higher than the 10 in the other developed nations. So this has been our big focus for the last few years, as why is this, and what can we do to decrease that rate? So this is a slide from our Maternal Mortality Review Board, and we actually review all pregnant deaths within women who are pregnant or die within 1 year of the pregnancy. So it's a little bit encompassing more than what the maternal mortality rate, because that's just within 42 days. And what we as the committee try to decide is, first we decide, was that death the actual, what was listed on the birth certificate, the actual cause of death? That's the first thing we decide. Then we try to decide, was it pregnancy related? And if you look at the second bullet point, we see pregnancy related deaths or death from a pregnancy complication, preeclampsia, eclampsia, or a chain of events initiated by the pregnancy. And one of the ones that I find really interesting in that situation is like, it could be a homicide or like from domestic violence. So as we all know, pregnancy is an increased risk for domestic violence if it's already occurring. And so if a woman got pregnant, that aggravated the already present violence, and then she ends up with a homicide, that's a pregnancy related death. And sometimes that's hard to determine, but that's one of the things that it can be pregnancy related. Or finally, aggravation from an unrelated condition by the physiologic effects of pregnancy. So if the mom has a valvular heart defect, or if there's something going on, significant renal disease, and the mom continues pregnancy, and then the increase in blood volume leads to a chain of events that ultimately leads to her death, that is a pregnancy related death. And the others, when the woman is pregnant, but it's not related, are classified as pregnancy associated, but not related. And so as you can see from our little umbrella over there, a lot of these deaths are not pregnancy, only a small percent of the deaths are actually pregnancy related. And then the final thing we do in our committee is we try to determine if that death was preventable. And if it is preventable, is it preventable with good chance or with some chance? And that's essentially how our committee works. And so we focus a lot on the pregnancy related deaths because those are the ones that are part of the MMR, that rising MMR rate, and those are often the places where we can make interventions. In the United States, 700,000 women lose their lives each year as in relation to maternal mortality. So this is just a pictograph of those 700 women, which could really be a lot of us females out there. So if we're losing women, what are the causes of these deaths? And if you look at pregnancy-related deaths between 2014 and 2017, you can see that cardiovascular complications is number one, and that's persisted throughout the years. Infection, cardiomyopathies, hemorrhage, thrombotic events, PEs, and then cerebral vascular accidents. And then there at around 7% is our hypertensive disorders of pregnancy. And this number has also remained stable over years at about 7% are being caused by hypertensive disorders. And the reason that these things stick out in my mind is this is a very treatable condition. Sometimes I can't predict when a PE is going to happen, or we have no control over an infectious process necessarily. But hypertensive disorders, we try to predict, and we feel like if we follow people close enough, we can make a difference. So again, this is from our Tennessee MMR committee. So in terms of maternal deaths in 2017, there were 78 maternal deaths. In 2018, there were 82 maternal deaths. And in 19, we had a good year. We only had 62 maternal deaths. We're currently reviewing all the 2000 data, so that information we don't have yet. But after these 3 years, we were able to get enough data to group together and say, hey, let's look at our Tennessee deaths. And so that's 222 total deaths in that 3-year time frame. And 67 of those deaths we deem to be pregnancy related. So, and if you look for our Tennessee deaths, preeclampsia and eclampsia comes in second. 10 of those 67 deaths were related to preeclampsia. And these are those 10 deaths that I mentioned in the beginning that were deemed to be preventable. So if we know that we have this morbidity and mortality, well, when does the clock start ticking? When can we intervene? Where can we make that difference? And the 5 biggest complications from severe preeclampsia or eclampsia is acute renal failure, pulmonary edema, respiratory distress syndrome, cerebral vascular accidents, and then mortality or death. And so one of the important places where we really can make a difference is with strokes. It's a rare complication, at only 32 per 100,000, but 10 to 13% mortality rate when it happens. So we have to remember that intracranial hemorrhage is more common in the pregnant population than in the non-pregnant, which basically meaning that at the level of blood pressure needed to stroke in a pregnant person does not have to get as high as you would expect for a non-pregnant person. And we cannot forget too that strokes, we think most occur around delivery, but they can still occur in the postpartum period. So we often feel like, oh, okay, mom's delivered, I've done my job, I'm not, I don't have to focus as much, but we do. If intracranial hemorrhage and strokes are where women are dying, then this is a time, and it can still happen after delivery. We don't need to take that deep breath that mom is delivered. We have to be vigilant and aware that she is still at risk. And just a little number from one of the studies, women with preeclampsia are 12 times more likely to have a stroke than women without. So I'm going to read this little commentary word for word because I think it's fairly profound. Cerebral hemorrhage secondary to uncontrolled hypertension remains a leading cause of death in women with preeclampsia. In all too many cases, chart review reveals untreated severe hypertension preceding the event. This is particularly tragic given the widespread availability of effective antihypertensive agents. No hospitalized pregnant woman with a blood pressure over 160/110 will be harmed by a single dose of medication, yet many women will benefit. Therefore, we recommend making this one an automatic response. And this was from the Green Journal in 2012 when we were, bringing up all the acute urgent treatment, hypertensive urgency and acute treatment. And I really felt that this was just so impactful in your mind because you're like, they're right. I'm sitting here debating whether or not I treat her or do I wait my full 4 hours before I get my diagnosis of preeclampsia. But if we're having any doubt, just treat them, and then we can start and slow down, take care of mom, and then we can try to figure out exactly what's going on. So this links us right into the second segment, which is treatment and guidelines. So first, we need to talk about the risks of just severe hypertension. And we focused on a few of those earlier with our stroke and edema and kidneys. We can't forget about placenta abruption, the need for cesarean delivery, and postpartum hemorrhage. And then when we think about the decrease in blood flow to the placenta, we can also see the fetal sides of the fetal effects like stillbirth and perinatal death, growth restriction, as well as preterm birth and multiple complications that come from a preterm delivery. Some of the most severe some of the women with the most severe hypertension are being delivered at these severe prematurity, and therefore having multiple complications in their babies. And there's long-term effects. I just literally earlier this week delivered a 17-year-old with preeclampsia, and when I went on her postpartum rounds, I was telling her, and don't forget in the future when your primary care or whoever you see asks you if you're healthy, you're like, yeah, I'm totally healthy, no medical problems. Or I said, if anybody asks you if you have medical problems, you're like, yeah, no, I'm healthy. Oh, but I did have preeclampsia when I had my first baby. Because it's important. There are long-term implications, development of chronic hypertension, ischemic heart disease, congestive heart failure, and even an increased risk for cerebrovascular accidents in the future. So no hypertensive talk is complete without reviewing the types of hypertension in pregnancy. So just to remind everybody, and just a basic review, which many of you probably already know, chronic hypertension is classified as elevated blood pressures coming into pregnancy or the development of 140/90 less than 20 weeks. Gestational hypertension is when you develop 140/90s 2 occasions, 4 hours apart after 20 weeks. In the absence of proteinuria or systemic signs and symptoms. Preeclampsia is elevated blood pressures with the proteinuria or with some other systemic signs such as persistent headaches. I say persistent because they need to be not resolved with Tylenol. We can't just one elevated blood pressure and a mild headache that goes away is not considered preeclampsia. And then there's preeclampsia with severe features, and our severe features are either blood pressures 160/110, or a kidney creatinine above 1.1, platelets less than 100,000, elevated LFTs, or then we get into our end organ damage where we think about pulmonary edema, right upper quadrant epigastric pain, or our neurologic things like visual disturbances or unrelenting headaches. What's really interesting about preeclampsia and eclampsia is just, I mean, I'm not that old, but I'm not young either. It's time for me to face these facts. When I was a med student, the diagnosis of preeclampsia was a triad. There was a triad that was called like a triad, and you had to have two of the things in the triad. You had to have edema, elevated pressures, or proteinuria, and you could have any two of those three. Then by the time I was a resident, we had dropped out the edema because the edema was so common, and we were overdiagnosing. And then when I was a resident, you had to have elevated pressures with proteinuria. That was preeclampsia. Well, by the time I finished fellowship, we had dropped out the proteinuria, and you could just have elevated pressures without proteinuria, but with some other systemic sign and symptom and still be classified as preeclampsia. So it's just interesting to see the evolution of the way this disorder has been reclassified. And they did that because we were getting a little too rigid in some of our things. And it's clearly a spectrum. There is, you know, some people with elevated pressures are like, and again, this is another big point that's changed since I've been practicing. Before, with gestational hypertension, we thought that was not really the same. Now we're basically treating severe gestational hypertension the same as we treat preeclampsia with severe features. We're doing magnesium, we're delivering earlier. So there are definitely differences, and things have evolved over time, and we have to be willing to adapt and change, and to make sure we're not missing things. Women that could get sick on us that we're not paying attention to because they didn't get the label of preeclampsia. And that's some of the reasons, and some of these changes that have been made is to work towards recognizing and intervening and treating severe range pressure so that we can make differences to kind of decrease that mortality rate. And then another one that's listed here is chronic hypertension with superimposed preeclampsia. And that's whenever it can be somewhat of a difficult diagnosis. And a lot of people will say, well, is it superimposed severe preeclampsia, or is it superimposed pre-E without severe features? And so this is a really hard one, I think, because a lot of people will say if it's superimposed, it's severe by nature of being superimposed. But I don't know that that's necessarily always true, because, you know, that means we have to deliver after 34 weeks. And, you know, there's a lot of implications when we classify somebody as with severe features. So anytime they're superimposed on chronic, I think we have to, you know, really get some extra help involved to make the ultimate decision of, you know, how do I need to follow this patient? When do I need to deliver? So, oops. Oh, okay. So the people who are at risk for the most morbidity are the severe range blood pressures. And that's kind of where we're focusing. Whenever we have a systolic above 160 or diastolic above 110 for two readings 15 minutes apart, we need to take action. And that's kind of where this most recent push has been moving. It's part of TIPQC's project, and it's kind of part of ACOG's as well. So let's first talk about how we check that blood pressure. Get on one of my soapboxes. You want to make sure patients are in seated position, legs flat, and that they've been resting for 5 minutes. In a busy OB office, I recognize that that is probably a little unrealistic to think we're going to be able to bring every woman in and have them sit for 5 minutes. And in most of our population, it's probably that has normal blood pressures, 2 or 3 minutes is probably sufficient. But I always tell my moms that we're following on a regular basis that are coming back 2 or 3 times a week for blood pressure checks. I want them to be resting for at least 3 and preferably 5 minutes. I tell them, don't let the MA put the blood pressure cuff on right after you've walked back, because I need to know what their real blood pressure is. I don't want that slightly false elevated because they've been active and moving. You also have to make sure it's an appropriate size cuff. There's measurements online. It's like you want to be 80% of you want the cuff bulb to be 80% of the arm circumference. There's equations that you can look up. There's cuff size, but essentially most of us have the small or the adult, typical adult, and then the adult large cuff. And if you use one that is too small, it will falsely increase. If you use one that's too big, it will falsely decrease. And those are things that we have to take into consideration. And I'm not a small person, I'm overweight. But I was like, no, I'd be a normal size cuff. And then we like got out the measuring. This was a few months ago. We actually got out a measuring tape, measured my arm, looked through everything. And I'm like on the borderline of needing a large cuff. So I think that's, if we're ever in doubt, maybe we do need to measure, or we need to get like more specific as, okay, I'm using the absolute right size, because it can make a difference in what we do. And again, if we have any elevation of 140/90 in the office, you want to make sure you have a repeat within that 15 to 30 minute time frame. And if it's elevated, we've got to start the workup or some form of evaluation for preeclampsia. And here's my soapbox. Please don't reposition to either side. So I'll get a referral for a patient for IUGR. And they'll have maybe a borderline mildly elevated pressure, and they'll have all the risk factors: first pregnancy, AMA, and now they've got IUGR. And I'll be like, well, I'll start talking about blood pressures, and they'll be like, oh yeah, my blood pressure was elevated last week in the office, but when I went on my left side, it got better. And I always cringe a little bit when I hear that, because in my mind, is that a missed opportunity that I could have diagnosed with preeclampsia? Am I lucky that I didn't miss something more severe and something bad happened in that time frame? And did I miss the opportunity to intervene and give steroids, or to do something? Because what if she showed up on my doorstep and now needed to be immediately delivered? So whenever we have these elevations, please don't put them on their left side and get a lower number and feel good about it. It's good if it does come down, but it should not stop our evaluation and workup for preeclampsia. So most recent ACOG committee opinion for the emergent therapy of acute onset severe hypertension is pretty good. I love the logarithms that they have in there for the management and our medications to use. This was published in February of 19, so it's not recent. And this is the one that we tend to use in all of our protocols here at UT, and probably many throughout Tennessee. So essentially, they focus on treatment, and they conclude that introducing standardized evidence-based clinical guidelines for the management of patients with preeclampsia and eclampsia has been demonstrated to reduce the incidence of adverse maternal outcomes. Great. So essentially what they're saying is we need easy go-to plan of care once we see patients with this disorder. And so what time frame should we be treating severe hypertension in? Is it 60 minutes, 30 minutes, 15 minutes? They, in this bulletin or in this committee opinion, they also give us a little bit of reference for that as well. So they say that we need the mechanisms in place for prompt administration. And for us here, this is translated into nurse-driven protocols. And I think this is, again, I said there's not a lot of earth-shattering or groundbreaking information from our talk today, but this is one of the things that if it's not at your institution, perhaps this is something we can work towards, or you can work towards, is getting nurse-driven protocols without needing the physician orders to start, and making sure that it's starting within that 30 to 60 minute time frame once that the severe hypertension has been confirmed. And ultimately, we're trying to reduce the risk of maternal stroke and other of our severe issues that lead to that maternal morbidity. And so our goal is not necessarily returning that blood pressure to normal, but the goals are to prevent the end organ damage, to prevent us from going on to develop seizures, to develop pulmonary edema and renal failure. And then again, the goal is for immediate and prompt treatment. So what medications should we be using to treat severe hypertension? So the top three are the most common, and I would say probably the top two are the most common. Labetalol and hydralazine IV, as well as oral immediate release nifedipine, are all appropriate for the use of severe acute hypertension. You can see the way their mechanism of action and then their onset in the far right side. And I stop here for a second and say that throughout my residency, my fellowship, I've always been an IV labetalol or hydralazine person. In my head, it makes sense. It's IV, it's going to work quicker, and perhaps the onset of action is a little bit quicker. And to me, that was most important. And I knew that immediate release nifedipine was approved and considered a possible option, but it just wasn't necessarily my go-to until a few years ago. And we're going to get to that study in the next slide. I included oral labetalol as well as long-acting nifedipine here, just to note that while they're good and they're appropriate for women in long-term treatment, they're not appropriate in the acute setting. So their onset of action is not the correct and not the right amount of time to be using in the acute setting. So coming back to this oral nifedipine versus IV labetalol. So there were several older studies that actually showed that these two were equivalent, and perhaps that oral nifedipine could have been superior to IV labetalol. But it wasn't until this study that was published in January of 19 in the European Journal of Obstetrics, Gynecology, and Reproductive Biology that I can get clicked finally in my head. This study was a randomized, double-blinded controlled trial. So they actually gave patients medicine that could have been IV or oral, and they didn't know which one was which. They dosed it every 15 minutes. And ultimately, as you can see, the labetalol took 36, and their goal was number in minutes that it took to get to the target blood pressure. So time that it took in minutes to get to that target blood pressure. And as you can see, it took labetalol 36 minutes and 2.4 doses. And it took oral immediate release nifedipine 27 minutes and 1.8 doses. So perhaps oral nifedipine is superior to labetalol. According to this trial, in fact, it is. And so now our hospital protocols here have absolutely taken this study into consideration, and it's one of our first line agents that we are now using here at UT. So when we talk about our ACOG guidelines and what the committee opinion, we've talked about their recommendations, we've talked about what to use, but do guidelines really matter? And like I mentioned, a nurse-driven protocol, would it make a difference? So this is a super interesting study that was done in the HCA hospital system. And so they have, throughout their large hospital system, they can collect great information and numbers. And so they looked at maternal deaths in 2000 to 2006, and then 2007 to 2012. And in the middle of that, they instituted these protocols. And in our situation, what we're looking at is this hypertension-related protocols and what kind of impact they had on maternal deaths in relation to these protocols. And they're just checklist nurse-driven protocols for treatment of severe hypertension. And what they saw was, after they instituted the protocols, there were 0 deaths from intracranial hemorrhage. And they went from 15 deaths related to preeclampsia prior to institution, and only 3 deaths related to preeclampsia after they instituted the protocol. So yeah, protocols can make a difference, and here's a study to prove it. And I think we see a difference in our hospital as well. So this is just from that HCA system. You can see it's nothing incredibly or different. It's just simply to say, hey, notify the physician, but go ahead and give the medication, repeat it in this, and just kind of lays out what logarithm to follow, just like that ACOG committee opinion shows. And I'm going to have a little picture of that in a sec. So guidelines in real life, are they able to follow? And this is essentially what came out of the ACOG committee opinion. They lay out, if you're using, first of all, they say, recognize your blood pressure, make sure you're using the right cuff in the right position. It's not lying flat. It's semi-reclining. That's like thinking they're on our stretcher in triage. Repeat in 15 minutes. Are we still elevated? All right, now we've got to institute our protocol. We consider MAG, start putting it in your mind, on the back of your mind, but that doesn't necessarily mean start it. And then it goes down through, if you're choosing IV labetalol, you give this dose, recheck in this many minutes, then give this dose. The same for hydralazine. It tells you when to change over when you're not working and you need to switch over to your other medication. So it has them for all three of our typical medications that we would use in triage. And this is straight out of that committee opinion. And I feel that this committee opinion, this logarithm, this protocol somehow in some way, shape, form, or fashion should be in all OB emergency rooms, all ERs in our region. I take transports for hypertensive emergency situations, and I can't tell you how I wish that they had this, because by the time they call me, they don't know, I should give IV labetalol or hydralazine, or even immediate release nifedipine. So if they had these listed quick, easy check button in their electronic medical in the EMR, they could just institute this protocol immediately. So this is something that I think that we need to push towards all places that provide any sort of obstetric care, including emergency rooms, to have this as a box, a pop-up box, as soon as a pregnant woman comes in with elevated pressures. And then as you go down through here, if we're not getting better, we need to start thinking about who else we need to involve. As we say here at UT, we always say we want to load the boat. So do we need anesthesia because I might be looking at going to a C-section? Do I need MFM if I'm not able to get control and I need more help, or even critical care if mama is looking pretty sick and we're thinking we might need more help with control? So once we reach that blood pressure threshold, we can't forget that once they're normalized or to the target range, not necessarily normal, but where we want to be, we recheck about every 30 minutes for an hour, and then at least every hour for a couple hours before you go to whatever floor-based protocol that you're on. So don't just go to that every 4-hour vitals once you're normalized. You admit to, often if we admit to our antepartum floor, that's an every 4-hour vital sign. But we need to remember, if we're admitting straight out, we got a few hours of closer follow-up before we can go to their typical standard blood pressure checks. Another caution is when we think about using labetalol, you have to remember that to caution with use in pulmonary edema and or a low heart rate. So if we're going down the logarithm for labetalol and you start noticing the mom's heart rate is dropping, we're going to need to switch over perhaps to one of the other agents sooner rather than going all the way down, because perhaps she doesn't need that second dose of 80. Maybe we need to go to a hydralazine quicker. The other thing is the anesthesia can do for us is if we're worried about cuff size and control and it's significant, then we can consider arterial lines that is more accurately reproduced. So we can't have a complete talk about treatment without talking about using magnesium for prevention of seizures. So it's typically a 4 to 6 gram bolus followed by 2 grams an hour, but make sure you look at your kidney function. Usually we're fine up to at least a creatinine of 1.5, but the closer we get to 2, the more we're going to have to talk about, should we just give a bolus and then check mag levels every 4 to 6 hours so that we know that we're still in a therapeutic range, and forego that 2 grams or 1 gram an hour. So here's a little plug for the TIPQC Hypertension Project. Like we talked about in the beginning, TIPQC is the Tennessee Initiative for Perinatal Quality Care. The Hypertension Project is currently one of their projects. And basically the institutions, hospitals within the state will enroll or apply to be part of a project. And we're going to gather information from each of the centers in order to have more of a large kind of quality improvement project for the state, and hopefully allowing us to change and improve our outcomes for mom and baby. So currently, once they organize the team from each hospital, they send out a project toolkit. So this is the hypertensive project toolkit, and they lay out what roles to follow and what information to record, and then report back to TIPQC so we can make recommendations. The TIPQC aims for the hypertensive project is to reduce the rate of severe morbidities in pregnant and postpartum women with severe hypertension by 20% by December of this year. And they're targeting all pregnant women up to 6 weeks postpartum that come in any form, whether it's the office, triage, antepartum, if they have severe range blood pressures, or they can also be chronic hypertension. So anybody with a severe range blood pressure can be enrolled in the project. And so currently that's just starting up, it's underway, and we will look forward to information that it brings us by the end of the year. But as part of organizing this whole project, they come up with some potentially better practices in regard to this toolkit. We've talked about a lot of these things, but one of the things we haven't yet talked about is low dose aspirin for prevention of preeclampsia. And certainly, while it's not anything profound, it is definitely standard of care now. Any women who is at the highest risk for preeclampsia, that's your chronic hypertensive, pre-existing diabetes, renal disorders, those women are recommended to take low dose aspirin anytime before 16, starting anytime before 16 weeks. Then there's the second tier of women with two of our little risk factors, including like history of preeclampsia at term, obesity, advanced maternal age, first pregnancy. There's a whole list of things that will classify you as needing a low dose aspirin for prevention of preeclampsia. And one of the other things that they mention, as we see, I like the fact that they are highlighting, don't forget that we can use oral nifedipine as a first line agent, especially when IV access is not available. So in terms of postpartum considerations, again, I mentioned that once mama is delivered, sometimes we're like, thank goodness, it's not on me anymore. I'm so much less worried, but are we? When ACOG first changed over how we classify preeclampsia, and we started talking more about hypertensive disorders, they made it part of that bulletin to say we need to monitor moms for 72 hours postpartum. So our residency kind of changed the way we treat, like our vaginal deliveries that were going home on day 2, started staying until day 3, so we could cover ourselves for those 3 days postpartum. Well, we kind of discovered that kind of created a bottleneck, and we couldn't get people off of L&D. We were getting a little bit backed up that way because our mother baby unit was full. So we, took a step back and kind of, said, hey, if moms are reliable, they have a home blood pressure cuff, they can probably go home on day 2. But we can't not think about it. We are, per ACOG, we need to be doing 3 days of monitoring. So if mom is not reliable, they don't have a home cuff, then maybe we do need to watch them in the hospital for 3 days after, even from a normal vaginal delivery. And then finally, super, super important is that 1 week follow-up. So that was also part of that new ACOG recommendation, that they watch them for 3 days and then have a 1 week follow-up. And as part of the MMR committee, this is something that we focus a lot on. Was the provider documentation at discharge recommending a 1 week follow-up? And that's for hypertension. So again, things have evolved and changed since I've started. When I first was a resident, probably a fellow too, once after discharge from the hospital, you had a 6 week follow-up. That was it. And then when these guidelines changed, the blood pressure people had the 1 week follow-up, but then it was still a 6 week after that, depending on what their blood pressure was doing. But in the last few years, we've changed, and now the recommendation is for, like, I think, a 2 to 3 week postpartum follow-up, depending on what's going on. And that's, check on mental health, check on breastfeeding. So there's been, and we focus a lot on that in our MMR committee. Was the appropriate follow-up recommended and followed, but at least recommended on our end as the healthcare provider? And so, checking time. So we want to make sure that we are absolutely following that. So going to move on through summary. It's an important, severe hypertension is very important to that rise in maternal mortality. We need to treat quickly. Women are at risk for stroke. And if their blood pressures are greater than 180, they're less likely to have spontaneous resolution, and we probably need to think about treating quicker. So pitfalls, please don't put people on their left side, call it normal and send them home. Don't check too frequently, don't not recheck, and don't give oral labetalol as a first line agent. And then another pitfall that I haven't touched on is not having medication readily available on the unit, or if the nursing staff is not educated in that they can initiate the nurse-driven protocol, or educated in we need treatment within 30 to 60 minutes. So this is a good place for nurse education in terms of, hey, we want treatment in by that 30 to 60 minute time frame. And then there's our no policy for administering medication without an order. So finally, let's talk a little bit about racial disparities. So this question was originally in the TIPQC PowerPoint that they created for us with me to ask you guys, And, is there a race that's at higher risk for hypertensive disorders in pregnancy? And I think obviously yes, Black women are at higher risk. I left this question mark in here rather than deleting the slide because I wonder, are Black women aware of this? So the CDC published recently their information from that they gathered from 2007 to 2016 on racial and ethnic disparities in pregnancy-related deaths. And this information is quite profound. If you look on the basic level, in terms of pregnancy-related deaths, there is 3 times increase for Black women compared to white women to have a pregnancy-related death in the United States. And so you might say, okay, well, maybe this is concentrated in areas that are more at-risk population, more heavier states, less, they're not as good in that state, or, maybe there's something to do with the state, or in significant areas. So the first thing they did was they broke it down and they said, well, let's look at states that have a high maternal mortality rate, a medium maternal mortality rate, and a low maternal. Maybe that'll be different, and we'll see it'll be only in places with high maternal mortality rates. No, 3-fold increase across the board, no matter whether that state had a high or low overall maternal mortality rate. So that was interesting. So, okay, fine. Maybe it's over time. So this data is from 2007 to 2016. So maybe we weren't as good medically in 2007 as we are in 2016. No, again, if you look at these graphs, the distribution is relatively the same over all these years. So it persists a 2- to 3-fold increase for women of color for their mortality rate to be higher compared to white women. And then you say, okay. So maybe there's an age difference. Maybe it's, more younger women, maybe younger Black women, more of them are having babies. Maybe there's an age difference. And that's why we see it. There's more of them having it. So we see a higher number. But actually, the inequity increases by age for Black women, as well as American Indian and Alaskan Native women. And in fact, by the time we're above 35, it's 4 to 5 times that of their white counterparts. So another one, and then finally, the one that really got me when this data came out a couple years ago, and the one that really shook me was education. So in my mind, I thought, well, maybe it's, younger and uneducated women, not aware. They don't know that they need to take health that serious. But again, it was the opposite. The perinatal mortality rate for Black women with at least a college degree was 5 times as high as white women with a similar education. My mind was blown when this data came out. I was like, why? So clearly there is issues with our healthcare treatment and delivery of these educated women, because we can't just pass it off on any one thing. So when we look at race disparities in preeclampsia and hypertension, there is absolutely some genetic and social factors that play a role. So in regards to social factors, there's mistrust of the system. And obviously it's been around for many years. It dates back to when there were treatment and surgeries and trials on people without their consent. And a lot of us feel like, oh, it's been so long ago. Certainly that is not present anymore. But it's real. It's absolutely still present. And I think this prevents people from coming into care. And I think it prevents them from trusting the care that we're trying to provide. I realized this even more so when I listened to Michelle Obama's book, and she was talking about how it went on in her family. So it's a real thing. There's genetic predispositions. They're predisposed to more underlying medical conditions like obesity and hypertension pre-existing to pregnancy. They also have some variable response to medication and then adherence to protocols because of that, or adherence to treatment because of that mistrust of the system. But all of this plays into, we need to recognize that these women are at an increased risk, and we need stratification tools that we can place them into and classify them into ways that we can treat them better. We need novel, culturally specific treatment strategies to get them to trust us and to make sure that treatment does work. And finally, we need some advancing research ethics, research efforts in ethnic data collection so that we can gather all this information we have and try to figure out how we can better treat and better care for these women. So after delivery, it's not over. We have to remember that postpartum follow-up in non-Hispanic Black women is less likely to be appropriate. And that's in terms of that postpartum, initial postpartum, as well as the intra-conception care. So when they're not pregnant, between the next pregnancy, are they getting the medical care? Are we doing a handoff to the medical team that will be taking care of them with their chronic hypertension? Because maybe she did well this pregnancy, but maybe she doesn't take care of herself well before the next, and now she comes into the next pregnancy even worse off. So this is a time too where we can't forget that we can make a difference. So is there bundles that look at actual racial disparities? And there are. And ACOG talks about these in their committee opinion 649. That is mostly it was from 2018, and it was meant to talk about the underserved population. But in that committee opinion, they recognize that in order to reduce healthcare disparities, that women's health providers must engage in activities to eliminate this disparity gap. And the AIM is it's the Alliance for Innovation on Maternal Health. That's what AIM is. And so ACOG aims have bundles that are basically trying to recognize and help us move towards best practices. And so one of the first best practice models is allowing us to identify who we need to be aware of. So, and when we're trying to identify, we want to, accurately establish the system to identify these people. We want to make sure that our office staff has the education to help document and train. We want to train them so they can document the actual race and then the demographics, train them on how to perform that intake visit so that they are gathering the information properly. And we want to make sure that patients and family and community know we're collecting this information to help them and not to target them. So first, we're trying to identify and record the people that we're trying to help. And then we want to move towards recognizing and preventing things. And one of the most important parts of that is recognizing our implicit bias. We all have implicit bias. It's the way we were raised, the residency we trained in, the local culture that we live in. All of those are going to give us implicit bias. And we need to make sure that as the staff and the providers have education that allow us to recognize those and overcome the way that it may impact our delivery of care. We can do this through grand rounds and lectures, education, office staff training, any way that we can to make sure we're bringing out this and trying to overcome it. We also want to make sure that patients have access to their health records so that they understand what they have, and it's in a way that they can understand it, and way that they can interpret what we've written to know what their actual conditions are and what the significance of that means. And then we want a reporting mechanism for families and patients and staff to report anytime they feel there is inequitable care or an episode of misconduct or disrespect. And if we're so we're identifying the people, we're recognizing the things, and now we need a response. So we want to engage in best practices for shared decision-making between the patients as well as the providers. We want to ensure timely and tailored response to those reports of inequity or disrespect. And then finally, we want to make sure that as patients move through the healthcare system, that we help them with clear understanding. And this is where my interpretation of this is that I don't just say to the triage provider, give her preeclampsia precautions. I say to the patient, I meet them eye to eye, and I say to them, and know that they understand and they recognize the importance of if their blood pressure reaches this critical level, you have to come back to triage for that. These are the important signs you have to watch out for. Don't dismiss that headache that doesn't go away. Don't dismiss that epigastric pain as bad heartburn. Please come back to the hospital. So it's more than just give them information. It's give them information that they clearly understand. And then if we're going to do all this, we've got to have, ultimately, we want to build this culture of equity that includes systems of reporting, response, and learning. And that's for all of us. We want to kind of develop a disparities dashboard. We want to be able to incorporate all this information into one area. And if we're gathering it, be able to use it towards how many people identified as this race had this outcome. And this is going to take time. And one of the things that I always that I want to point out here too is we want to consider the role of race and ethnicity, other social determinants of health when we're conducting our multidisciplinary reviews. So I thought of this as in our M&Ms, like we do resident M&Ms once a month, and in our root cause analysis that we do, and we've done this in the MMR committee, where in the last year we've actually added a checkbox to our forms that we fill out that says, did discrimination play a role in this mom's death? And in our M&Ms and in our root cause analysis, I feel like we should add a checkbox that says, was there some form of, and it doesn't have to be even broader. In this situation, we're talking race, but it could also be, was this person discriminated against for opiate use, or was, there's multiple things that we need to broaden our minds out and open our eyes to where can we identify things and change our plan of care and make a difference. There's some readiness resources. I know we're running out of time, so we're actually done, but this will be on the PowerPoint that's recorded. And so in conclusion, it's these 700 women that we're talking about today. I really hope that, again, nothing's been earth shattering, and significantly new, but perhaps there's a few things that you can take home and we can learn how to help, these 700 women. So we have questions, but before I do give thanks to Sarah Osmondson, as well as Dr. Sarah Osmondson, as well as Dr. Connie Graves, both out of Nashville, for putting the TIPQC portion of these slides together. And then if we have a second, I will share that with you guys as well. But I want to ask about any questions first.
Dr. Wolf, I do have a quick question. Sorry. Thank you for your expertise. You focused a lot on inpatient care, which is amazing, and I know that's where your practice takes you. But is there room for collaboration for outpatient clinicians, for patients who, we identify that their pressure is severe and they're in a geographically isolated area of East Tennessee? Do we need to be treating them first with oral nifedipine immediate release and then sending them to triage?
So that's a great question. And that's kind of like where I thought about these outlying ERs when they call me. So, I mean, you're not an ER, but I would say to them, I want them to treat before they send, but I don't know that I would treat before a 30-minute window. And that's like, I think it's a question of, you got your diagnosis. If they've been in your office for a 30-minute time frame and we got a second one. And the other thing is, if it looks like a duck quack, if they're never had elevated pressures before, now they're 160s over 111, and they have new 2 or 3 plus protein, it's preeclampsia. So, I wouldn't hesitate to treat that person if we had oral nifedipine. It's just the logistics of keeping the medication in the office and all of that. But, the main goal there is to make sure that's recognized and get sent to the inpatient. But yes, we could treat on the outlying places, and specifically that's where I like to think of the outlying ERs. They need to know these guidelines and start that treatment immediately. I'll show you all, if there's no real other major questions, then I'll show you all just an interesting, let me see if it'll work. So one of our residents said, and she said, okay, this practice bulletin says we need to treat in a timely manner. So what are we doing here at UT? So she asked, do we identify in an appropriate manner? Do we treat, and do we treat in a timely manner, and do we treat appropriately? She looked over 5 months, just basically searched ICD-10 codes for hypertension. She identified 113 patients, 69 had severe range pressures. This is a little funky slide because there's negative numbers over here, but that's because we included the office elevated pressure. So, it's hard to say that, this did the nurse notify the provider within a timely manner? So this one's not so much useful, but this one is, did we treat in a timely manner? So of the people who had severe range pressures, 72 got treated within an hour, but 27% didn't. So that's a pretty decent number at a tertiary care center where we thought we would be doing really well with something like that, but we didn't. And she broke that down to say, of those 27%, what happened? Some of them got, 5% got nothing, 15% got magnesium only, which is obviously you recognize there's severe pre-E and you didn't even treat the pressures. 36% got it, but then the medication came a little bit later. And then some of them got only PO labetalol, which is also inappropriate in a severe setting. So out of this, we basically said there is some room for recognition, response, and standardized treatment, which is when we started focusing on our nurse-driven protocols out of labor and delivery. And that's been one of the biggest things that we've actually been doing lately, is making sure that all the nurses are aware and that those protocols are being enacted.
Dr. Wolf, thank you so much for such an informative presentation today. In our department, in a collaboration with OB and Family Medicine, we're creating a Caring for Motherhood Planner, and we definitely want to look through or watch the recording on this and add some of that material into that planner that we're creating. I know that we're out of time. Does anybody have any final questions before we end today's lecture?
You are more than welcome to email me or ask for anything. I'm happy to share protocols as well.
Oh, great. Thank you.